Hello, today we will discuss abnormalities of placenta, membranes, and umbilical cord. We will talk about placental abnormalities first. We will discuss abnormal shape or implantation, degenerative placental lesions, circulatory disturbances, hypertrophic placental abnormalities, and we will talk about placental inflammation. How you already know, the placenta is a crucial feto-maternal organ with both embryonic and maternal components. And the development of the placenta begins with the implantation of the blastocyst into the maternal uterus, and it evolves throughout the pregnancy. At the end of the first trimester of pregnancy, the maternal blood supply to the placenta is complete. The placenta has numerous and complex developmentally essential functions, such as nutrition, extraction, and immunologic and endocrine functions also. The normal placenta is a round or oval-shaped organ that attaches to the uterine wall and has roughly 22 centimeters in diameter. The placenta thickness is about 2 and 2.5 centimeters, and weight is usually about 1/6 of the fetal birth weight. Thus, our normal development of placenta is important for an eventual embryonic and fetal development. Here you can see the fetal surface of normal placenta. It looks smooth, glistering, and is covered by the amnion, which is reflected on the cord. The umbilical cord is inserted near or at the center of this surface, and its radiated branches can be beneath amnion. Here is a normal maternal surface of placenta. It's dull grayish red in color and is divided into 15 to 20 cotyledons. Each cotyledon is formed of the branches of one main villi stem covered by decidua. Placental abnormal shapes or implantations. To be classified as biparietate or triparietate, the 2 or 3 lobes of placenta should be separated by a membrane and be of equal size. There is no certain information of how multi-lobe placenta are formed. A biparietate placenta is one pregnancy may be followed by greater than expected frequency of biparietate placenta in the next pregnancy. This raises the possibility that some multi-lobe placenta have genetic origin. The umbilical cord must often insert into the membranes between the 2 lobes of biparietate placenta, but in about 1/3 of cases, it inserts into the larger of the 2 lobes. The 2 clinical manifestations of multi-lobe placenta most often cited are bleeding in the first trimester of pregnancy and the failure of one of the lobes to separate at delivery with consequent postpartum hemorrhage. There are also published reports that the B-lobed placenta increased in frequency with advanced maternal age and with maternal history of infertility. Antecedent risk factors include maternal cigarette smoking during pregnancy, mother being more than 34 years of age, excessive vomiting during the first trimester of pregnancy, diabetes mellitus, and one of the parents or sibling having a chronic seizure disorders. Taking all these factors into the consideration, multi-lobe placenta do not have any unfavorable short-term or long-term pregnancy outcomes. Also, you can see here a picture of second-rate lobe placenta. It's a small accessory lobe, less than one or sometimes more than one. It develops in the membranes at distance from the periphery of the main placenta, to which usually have vascular connection of fetal origin. The clinical significance of succulent lobes is retained into the uterus after delivery and may cause serious hemorrhage. Accompanying was a previa and dangerous fetal hemorrhage at delivery. You can see here in the picture succulent lobe placenta. Another shape and implantation abnormalities is membranaceous placenta. Here how you can see in the picture, all of the fetal membranes are covered by functioning villi, and the placental develop as a thin membranous structure occupying the entire periphery of the chorion. Clinical significance is that it has serious hemorrhage associated with placenta previa or placenta accreta. Another abnormal shape, it's a ring-shaped placenta. Placenta is annular in shape and sometimes a complete ring of placental tissue. We have here variant of a membranous placenta. We have here tissue atrophy in a portion of the ring, and horseshoe shape is more common. It's a very rare case of this ring-shaped placenta. We have only rare cases of this shape. And clinical significance is that we have antepartum and postpartum bleeding and fetal growth restriction. Also, a fenestrated placenta is one of the abnormal shapes and implantation. We have in the center portion of a discoidal placenta is missing. In some instances, there's an actual hole in the placenta, but more often the defect involves only villus tissue with a chorionic plate. Clinical significance is that it's usually mistakenly considered to indicate that a missing portion of placenta. Also, we have placenta accreta, placenta increta, and percreta. It's actually abnormal placental implantation. Sometimes we call it abnormal invasive placenta also. It is actually sometimes not diagnosed before delivery. If it's not diagnosed before delivery, it can lead to catastrophic postpartum hemorrhage with life-threatening complications. Risk factors include increasing maternal age, previous cesarean delivery or myomectomy. It's also a risk factor includes multiparity and previous intrauterine maneuvers. When actually here a placenta villi attached to myometrium rather than the decidua. When the villi attached to myometrium, we call it placenta accreta. When the chorionic villi penetrate to myometrium, it's called placenta increta. And whereas placenta percreta extend into the uterine serosa or eject organs, placenta increta and placenta percreta are rare disorders which represent 20% of cases of placenta accreta. Then we have extrachorional placentation. It is when the chorionic plate normally extends to the periphery of the placenta and has a diameter similar to that of the basal plate. With extrachorional placentation, however, the chorionic plate fails to extend to this periphery and leads to a chorional plate. One of the forms is a circumvallate placenta. Here, fetal surface of such placenta present a central depression surrounded by a thickened grayish white ring. Ring is composed of a double fold of amnion and chorion with the degenerated decidua and fibrin in between. Within the ring, the fetal surface presents a usual appearance, except that the large vessels terminate abruptly and margin of the ring. And clinical significance is that it's usually antepartum hemorrhage from placenta abruption and fetal hemorrhage, preterm delivery, perinatal mortality, and fetal malformations. Circumambulate placenta, we have ring, does not have central depression with the fold of membranes. You can here see the picture of circumambulate placenta. It attached edge with a ridge of fibrin, demarking the edge of the vascular plate. It often only involves a portion of the circumference. And another picture of circumambulate placenta, peripheral cup-like insertion of the membranes at the placental surface. Another placenta abnormalities, it's degenerative placental lesions. Cause of these lesions, it's trophoblastic aging or impairment of the uteroplacental circulation with infarction. Also, it's a deposition of calcium salt in the heaviest of the maternal surface in the basal plate. Further deposition occurs along the septa and both increase as pregnancy progresses. Calcification, 10 or 15% of all placentas we have. By gestational age, by 33 weeks, some degree of calcification may cause maybe on the half of placenta, and it's easily diagnosed by ultrasonography or MRT. Here you can see the picture of calcification of placenta. Another circulatory disturbances is placental infarctions, multifocal choriamnios, placental lesion. It's cause of continuum from normal changes to extensive and pathological involvement. Incidence 10% of 500 consecutive placentas from uncomplained term pregnancies. Several types, they may located at placenta margin, maybe also underneath the chorionic plate, and chorionic infarct downward with pieces as the intervillous space, and intercotylindary septa meet and form a column of cartilage like maternal extending from the maternal surface to fetal surface. And here you can see the in the picture A, it's a placenta infarction. Picture B shows that it is fibrin deposit, and in picture C, it's normal placenta. Another circulatory disturbances, it's a maternal floor infarction. This extreme variant of peribilious fibrinoid deposition is a dense fibrinoid layer with the placental basal plate and is erroneously termed an infarction. The lesion has a thick, white, firm, corrugated surface that impedes normal maternal blood flow into the intervillous space. Actually, these lesions are associated with miscarriages, fetal growth restriction, preterm delivery, and stillbirths. These adverse outcomes occasionally recur in subsequent pregnancies. Unfortunately, their etiopathogenesis is not well defined, but some cases are associated with lupus anticoagulans. And also unsettled other cases may be associated with maternal thrombophilias. Actually, these lesions are not reliable imaged with prenatal sonography, but they may create a thicker bubble plate. Placental vessel thrombosis, when a stem artery from the fetal circulation in the placenta is occluded, it produces a sharply demarcated area of avascularity. A single thrombosis, it's 5% of placenta in normal pregnancies, and usually it's 10% of diabetic women. Thrombosis of a single stem artery will deprive only 5% of the villi of their blood supplies, associated with fetal growth restriction and stillbirths. Another hypertonic lesion of the Hornig villi, it's another placental abnormalities. Its enlargement of the Hornig villi is commonly seen associated with severe erythroblastosis, fetal hydrops, maternal diabetes, and maternal fetal syphilis. Circulatory disturbances of placenta margin, it's 90%, cause its occlusion of maternal uteroplacental circulation and normal aging. It's usually found around the edge of nearly every term placenta. Its dense yellowish white fibrous ring representing a zone of degeneration and necrosis. A lesion, we have numerous development of placental insufficiency. It's sick, centrally located, and randomly distraught. Preeclampsia or luteus anticoagulans. This conspicuous lesion arise after occlusion of the decidual artery, interrupts blood flow to the intervillous space. Necrosis of villus tissue developed from ischemia, its decidua, a conclusion placenta abruption. Another placental abnormalities, it's a placental inflammation. Changes that are now recognized as a various form of degeneration and necrosis were formerly described under the term placentesis. It's a small placental cyst with grammus contents were formerly thought to be abscess. Nonetheless, especially in case of preterm and prolonged membrane rupture, bacteria invade the fetal surface of placenta, and this all cause amniotes and spring to placental inflammation. Tumors of placenta. We will talk about gestational trophoblastic disease, chorioangiomas, tumor metastatic to placenta, and embolic fetal brain tissue. Gestational trophoblastic disease is actually a diverse group of interrelated diseases resulting in the abnormal proliferation of trophoblastic tissue. These tumors result from abnormal fetal tissue rather than maternal tissue. And during molar pregnancy, the stroma of Hornig will change its structure and become to swell and fill up with liquid and turn into bubbles of different size. Here in the picture, you can see the uterus, and inside the uterus, there is different size and different shape of bubbles, which are made from the stroma of Hornig villi. We divide gestational trophoblastic disease in complete molar pregnancies to incomplete molar pregnancy, invasive molar pregnancy, choriocarcinoma, and trophoblastic diseases of placental bed. Pathologic and clinical signification for gestational trophoblastic disease. Actually, we divide them to benign gestational trophoblastic disease and malignant trophoblastic disease. Benign gestational trophoblastic disease is characterized histologically by cyst swelling of Hornig villi, accompanied by variable amount of trophoblastic proliferations. It have increased risk of invasive mole and choriocarcinoma, and currently diagnosed at early age because of ultrasound examination and close monitoring of early pregnancy. Occurs at extremes of reproductive ages. And malignant trophoblastic disease, we divide non-metastatic and metastatic form. Metastatic form also can be high risk of malignant and low risk. Epidemiology of gestation trophoblastic disease. The incidence of malar pregnancy is about 1 in 1,000 pregnancies. It's high among Asian women, occurs 1 in 500 pregnancies, and in Caucasian women is 1 in 2,000 pregnancies. The risk factor is early maternal age or late maternal age. The previous, in the history, previous pregnancies with gestational diseases. If women have a low amount of vitamin A, and if she has history of spontaneous abortions, so this group of women are in the high risk factors for gestational trophoblastic diseases. So we divide, how I told before, to complete and incomplete more trophoblastic diseases. So this is a picture of complete mole. How you can see incomplete hydration mole, a hydration mole involving most of the chorionic villi and typically have a diploid karyotype. Histopathologically, the villus hydrops of a complete mole is characterized by extensive cavitation. The trophoblastic proliferation has circumferential distribution, hyperplasia, and cytological atypia. And intermediate trophoblasts of the molar implantation size characterized displays marked cytologic atypia. And in molar pregnancies, gestational sac, how you can see amnion and umbilical cord and fetal tissue are not found. So in complete hydration mole, we can see picture only of bubbles with different sizes, and there's no embryo, no umbilical cord, no fetal tissue. So all placenta is swollen by the stroma of changed Hornig villi. Complete moles generally have a 46XX karyotype, and the molar chromosomes are completely of paternal origin. Most complete moles appear to arise from an anuclear empty ovum fertilized by a 23X haploid sperm that then replicates its own chromosomes. But there are very rare cases. About 10% of complete moles have 46XY karyotype. The 46XY complete mole arises from fertilization of a nuclear empty egg by 2 sperm, while chromosomes in a complete mole are entirely of paternal origin. The mitochondrial DNA is of maternal origin. And there is a pathogenesis of partial molar pregnancy. So in incomplete mole, fetus cord amniotic membrane present some placenta. How you can see in this picture, it's incomplete mole. You can see here that the fetus cord and amniotic membrane is present, but some part of placenta villi is swollen. Have 2 population of Hornig villi. One is normal size, the other with trophoblastic proliferations. So we have fetus, cord, amniotic membranes, and at the same time we have the hornic wheels that changed its stroma and become turn into bubbles in different size. Um, Incomplete mole, it has triploid karyotype, fertilization of an apparently normal ovum by 2 sperms happen. Fetuses with partial mole usually have a stigma of triploidy and multiply congenital anomalies and growth retardations. Here is features of complete and partial herediform moles. So how you can see, they have different karyotypes. In the incomplete mole, we usually have fetus. Incomplete mole, fetus absent. In complete mole, we have amnion. In incomplete mole, fetal blood cells, but in complete mole, it's absent. Also, in partial mole, we have trophoblastic proliferation, focal but not severe, but in complete mole, it's diffuse and severe. Clinical course. So what we have in gestation trophoblastic disease, that we have a big size of the uterus. So if normally the uterus size is bigger, then it has to be in this period of gestational age. It's 50% more than its gestational age. And also during gestational trophoblastic diseases, we have thecal lutein cyst, usually on the both ovaries. It's probably 25–30% of all trophoblastic diseases. We have also complication of pregnancy, it's 10–25%, and post-malar gestation trophoblastic diseases also 6.8–20%. Incomplete malar pregnancy, so microscopic, it's enlarged, adenomatosis willi, and trophoblastic pathological diffuse proliferations, which involves all willi, so again, no fetus, red blood cells, and no amnion. And macroscopic is grapes-like vesicles of variable size, no embryo, no fetus, uterine size more than gestational age, and thecal lutein cysts. Usually we have thecal lutein cysts, it's probably 30% of all trophoblastic disease pregnancies. So in this picture, you can see molar pregnancy, complete molar pregnancy. How you see it's swollen will grow in clusters, which look like branch of grapes. And here also we can see the uterine wall, and on the right side it's complete malar pregnancy. So bubbles grows up very fast, and that is why and they are big sizes. That is why usually uterus more than it has to be in that gestational age. So uterus big in size. And partial molar pregnancy, how I told before, it's in microscopic, it's enlarged. Edematous willi, pathological proliferation we have of trophoblast is not significant. Is focal, scalloped edge of willi, embryonic or fetal red blood cells present. Macroscopic molar pregnancy does not involve all the placenta. Uterine size not always larger than expected, and thecal lutein cysts are rare in this form of pregnancy. Embryo, fetus, and amnions are presented in partial molar pregnancy. And you can see in these pictures maternal surface of placenta, and here is also partial molar pregnancy We have here baby is with triploid karyotype, fetus with triploid karyotype. Here also how you can see is partial molar pregnancy. So we have here fetus and we have placenta will swallowed by trophoblastic proliferation. And what we have clinical presentation, what we have usually patient have vaginal bleeding. It's usually in the first trimester of pregnancy. Probably it starts in 10-12 week of pregnancy. We also have hyperemesis gravidarum, and against significant enlargement of fetus, because how I told before, these bubbles grow up very fast. And we have miscarriage, and some patients have bleeding with these bubbles, so with cycles. Rare we have hyperthyroidism, early onset of preeclampsia, and rare we have descent of abdomen due to lutein cysts, and very rare form it's acute pulmonary insufficiency, convulsions we may have also. How we diagnose this? First of all, of course, we examine the patient. She will have, usually she says that she has bleedings. And when we do ultrasound examination, we will see the picture of the snowstorm in ultrasound. It's usually look like this picture of the snowstorm, or we can see the grapes in the uterine cavity. So this is a picture of complete malar pregnancy. But if we look in the computer tomography, we can see in this picture that it is incomplete malar pregnancy, because we have here, we can see here fetus, the parts of the fetus, and at the same time we see here these bubbles that with different size and different shape. And of course we will check the level of hormonogentropin, because we have here a huge amount of chorionic wheel stroma. Of course we will have high level of hormonogentropin. So usually it's twice higher than it has to be for that gestational age. So the main diagnosis for gestational age, gestational trophoblastic disease is of course ultrasound examination and a level of beta hormonogentropin. So in normal pregnancy, the level is at its peak at around 14 weeks, but here it's it's usually much higher in complete mole. But if we compare hormonogentropin level with complete and incomplete moles, so we will see that in incomplete mole and partial mole, it's high than in normal pregnancy, but it is low compared to complete mole. Of course, the highest number we get if we have complete molar pregnancy. And in ultrasound also we see lutein cysts. So this is a picture of complete mole pregnancy. This is the picture of complete molar pregnancy. Uterus is totally filled by cyst, and in this patient we also see in ultrasound examination lutein cysts. So partial molar pregnancy, often diagnosed of missed abortion or incomplete miscarriages. All abortuses should be histologically investigated. Yes, all of the abortions, no matter it's molar pregnancies or not, it's especially if it's molar pregnancy, it has to be histologically investigated. We have here in partial molar pregnancy, we have second endomatous placenta with embryonic or fetal tissue present. And also we have cyst changes in placenta. Management of malar pregnancy, two important directions, evacuation of malar pregnancy, and second is regular monitoring. So evacuation, of course, we will do curettage. It may be vacuum curettage. If it's it may be vacuum curettage, or it can be curettage and plus prostaglandins and oxytocins can be recommended to patient, but in some cases we can do hysterectomy, in which cases we do it if it's old woman who completed her reproductive plans, and we want to reduce the risk of post-molar thromboplastic disease. If risk factor exists, if she has Tekalutin cyst and significant uterine enlargements and level of herringotropin more than 10, so 1,000, and so we can recommend hysterectomy in these cases. The first management, first to treat is dilatation and curettage. And after that, of course, we have always checked the level of herringotropin, especially first weeks after curettage. Every week we check the level of herringotropin, and how you can see in the picture. So every week it gets lower and lower. And here's a picture of complete malar pregnancy. We have here a large uterus and Tekalutin cyst. And on the right side, it's a complete malar pregnancy after hysterectomy. And this is Tekalutin cyst picture. So after we check, after dilatation at curettage, we check herringotropin level. If after 56 days, 6 months within uterine cavity, if level is still high, we do curettage. And after 56 days monthly monitoring within 6 months after herringotropin normalization. And of course, we advise contraception after barrier methods can be chosen after normalization of herringotropin. And women with gestational trophoblastic disease, after we have a normal level of herringotropin, we advise them not to get pregnant for 2 years. Another type of gestational trophoblastic disease is invasive mole, invasive molar pregnancy. Here, molar will grow into the myometrium or its blood vessels and may extend into the broad ligament and metastasize to the lung and the vagina or the vulva. An invasive mole develops in approximately 10 to 20 of patients after molar evacuation and infrequently after other gestations. It is defined as a mole that penetrates and may even perforate the uterine wall. The pathology of invasive mole arises from hydatid form moles. There's an invasion of myometrium by heteropic hornic villi, accompanied by the proliferation of trophoblasts. A tumor is locally destructive and may invade perimenstrual tissue and blood vessels. The main markers, as with other forms of the gestational trophoblastic disease, maternal serum beta-herringotropin values are markedly elevated. And also radiographic features. It's kind of difficult to differentiate an invasive mole from other form of gestational trophoblastic disease in imaging. During the ultrasound may be seen as a echogenetic vascular mass invading the myometrium, and color Doppler interrogation will show high velocity and low impedance flow. So it's recommended to do pelvic MRI. During MRI, it often appears as a poorly defined mass that deeply invades the myometrium. Complete or partial disruption of the junctal zone may also be seen. The significant characteristics include iso-intense to the myometrium with scattered foci of high signal intensivity and mixed signal intensivity. So malar-like structure appear as tiny cystic lesion with the well-enchanged zone of trophoblastic proliferation in a mass of the invasive mole. With the penetration of tumor into myometrium, the invasive mole can appear as more aggressively entity compared to choriocarcinoma. And also we have chorioangiomas or hemangioma. Here, multiplied placenta choriangiomas in which a blood group A fetus based acutely into her O group mother. The mother showed evidence of acute hemolysis without anemia, and the fetus developed sinusoidal heart rate pattern frequently seen with the severe anemia. And also severe iron deficiency anemia is neonate as a consequence of chronic fetal to maternal bleeding for multiple small chorioangiomas. Large tumors provide an arteriovenous shunt that can lead to fetal heart failure. Another tumors of placenta, it's tumor metastatic to the placenta. It's malignant tumors rarely metastase to the placenta. It's melanoma, leukeomas, and lymphomas. Tumor cells usually are confined within the intervillous space, the fetus, and malignant cells seldom proliferate to cause clinical disease. Another tumors of placenta is embolic fetal brain tissue. Fetal brain tissue occasionally is seen embolized to the placenta or fetal lungs. It usually has been described with traumatic deliveries. And also this phenomenon is not without precedent because the brain tissue has been found in pulmonary veins following head trauma in older children and adults. Abnormalities of the membranes, its meconium staining, chorioamnionitis, and other abnormalities. Meconium staining, fetal passage of meconium before or during labor is common with cited incidents that range from 12 to 20%. Importantly, staining of the amnion can be obvious within 1 to 3 hours, but its passage cannot be timed or dated accurately. Meconium staining clinical significance, its prenatal morbidity and mortality is high. We have severe fetal acidemia, and usually we have cesarean delivery. And neonatal morbidity and mortality, high meconium aspiration syndrome. And serious, we have maternal risks. They are associated with amniotic fluid embolism. It's increased maternal mortality from cardiorespiratory failure and consumptive coagulopathy. And we have puerperal metritis. It's 4 times higher than in normal pregnancies. Abnormalities of the membrane, chorioamnionitis. Normal genital tract flora can colonize and infect the membranes, umbilical cord, and eventually the fetus. Bacteria most commonly assistant after prolonged membrane rupture and during labor to cause infection. Organisms initially infect the chorion and adjacent decidua in the area overlying the internal os, and subsequently progression lead to full sequence involvement of the membranes, how we call it chorioamnionic. Organism may then spread along the chorioamnionic surface to colonize and replicate in amniotic fluid. Subsequently, inflammation of the chorionic plate and of the umbilical cord may follow. And fetal infection may result from hematogenous spread if the mother has bacteremia, but more likely is from aspiration, swallowing, or other direct contact with infected amniotic fluid. Most commonly, there is microscopic or acute chorioamnionitis, which is caused by a wide variety of microorganisms. This is frequently cited as a possible explanation for many otherwise unexplained cases of ruptured membranes, preterm deliveries, or others. In some cases, gross infection is characterized by membrane clouding and in sometimes accompanied by foul odor that depends on bacterial species. So management here, it will be antimicrobial administration and expedient delivery. So other abnormalities, it's a cysts, amnion cysts. Cysts occasionally are found along the course of cord. They are designated according to their origin. True, cysts are epithelium-lined remnants of the allantoling or vital-lined ducts and tend to be located closer to fetal insertion site. In contrast, the more common pseudocysts form from local degeneration of Wharton jelly and occur anywhere along the cord. Both have a similar sonographic appearance. Single umbilical cord cysts identified in the first trimester tend to resolve completely. However, multiple cysts may portend miscarriage or unemployment. Cysts persisting beyond this time are associated with a risk for structural defects and chromosomal anomalies. Another anomaly is amnionodosum. The condition of amnionodosum is characterized by numerous small light tan nodules on the amnion overlying the chorionic plate. This may be scraped off the fetal surface and contain deposits of fetal squamous and fibrin that repeat prolonged and severe oligohydroamnions. And there are at least two band-like structures and can be formed by fetal membranes. Amniotic band sequence is an amniotic fetal disruption sequence caused by bands of amnions that entrap fetal structures and impair their growth and development. As the most widely held theory concerning their etiology is that early rupture of amnion results in adherence of part of fetus to the underlying sticky chorion. Amniotic bands commonly involve the extremities to cause limb reduction defects and more subtle deformation. They may also affect other fetal structures such as cranium, causing encephalopathies. Umbilical cord abnormalities can be in the length of the cord, in the cord coiling. We can have single umbilical artery, for vessel cord, abnormalities of cord insertion, cord abnormalities capable of impeding blood flow, torsion and strictures, hematomas, and cysts. So most umbilical cords are 40 to 70 centimeter long, and very few measure less than 32 centimeter, or very few measure more than 100 centimeter. Cord length is influenced positively by both amniotic fluid volume and fetal mobility. Short cords may be associated with fetal growth restriction, congenital malformation, interpartum distress, and a twofold risk of death. Excessively long cords are more likely be linked with cord entanglement or prolapse, and with fetal anomalies, acidemia, and demise. Because antenatal determination of cord length is technically limited, cord diameter has been used as a predictive marker for fetal outcomes. Some have linked lean cord with poor fetal growth and large diameter cord with macrosomia. However, the clinical utility of this parameter is still unclear. Cord coiling. Also, cord coiling characteristics have been reported. These are not currently part of standard sonography. Usually, the umbilical vessel spirals through the cord in a sinustral that is left twisted direction. The number of complete coils per centimeter of cord length have been termed the umbilical cooling index. A normal antepartum index derived sonographically is 0.4, and this contrasts with a normal value of 0.2 derived postpartum by actual measurement. Measurement, and clinically hypocooling has been linked with fetal demise, whereas hypercoiling has been associated with fetal growth restriction and interpartum fetal acidosis. Both have been reported in the setting of the trisomic fetuses and with single umbilical artery. Umbilical cord abnormalities, single umbilical artery. Occasionally, the usual arrangement of two thick-walled arteries and one thin, larger umbilical vein is altered. The most common aberration is that a single umbilical artery with seated incidence of 0.63% in live-born neonates, in 1.92% with perinatal deaths, and 3% in twins. The cord vessel number is component of the standard prenatal ultrasound examination. Identification of a single umbilical artery frequently promotes consideration for target sonography and possible fetal echocardiography as an isolated findings in an otherwise low-risk pregnancy with no apparent fetal anomalies. It does not significantly increase the fetal unemployed risk. But fetuses with major malformations frequently have a single umbilical artery, and when seen in anomalous fetus, the unemployed risk is greatly increased and amniocentesis is recommended. Amniocentesis is recommended. The most frequent anomalies described are cardiovascular and genitourinary anomalies. A single artery has also been associated with fetal growth restriction in some, but not in all studies. And also we have abnormalities of cord insertion. How we know the cord normally inserts centrally into the placental disc, but eccentric, marginal, or filamentous insertion are variants. The latter two are clinically important is that the cord or its vessels may be torn during labor and delivery. Of this marginal insertion is a common variant, sometimes referred to as a battledore placenta, in which the cord anchors at the placental margin. These are more frequent with multifetal pregnancy, especially those conceived using assisted reproductive technology, and they may be associated with weight discordance. This common insertion variant rarely causes problems, but it occasionally results in the cord being pulled off during delivery of placenta. Another anomaly is filamentous cord. Filamentous insertion is a variant of considerable clinical importance. The umbilical vessel characteristically spread within the membrane at the distance from the placental margin, which they reach surrounded only by a fold amnion. As a result, vessels are vulnerable to compression, which may lead to fetal hypoperfusion or acidemia. The incidence of the filamentous insertion is approximately 1%, but it is more commonly seen with placenta previa and multifetal gestation. And the very uncommon is the forked insertion, the topographic site of cord connection onto the placental disc is central, but umbilical vessels lose their protective wharton jelly shortly before they insert. As a result, they are covered only an amnion sheath and prone to compression, twisting, and thrombosis. And another umbilical cord anomaly is anomaly of cord insertion, vasa previa. This is a particularly dangerous variation of filamentous insertion in which the vessel within the membranes overlines the cervical os. The vessels can be interposed between the cervix and presenting fetal part. They are vulnerable to compression and also to laceration or avulsion with rapid fetal exsanguination. Vasopressor is uncommon, and Lee and co-workers identified it in 1 in 5,200 pregnancies. As a risk factor is beloved and subquinterent or low-lying placenta, multi-fetal pregnancy, and pregnancy resulting from in vitro fertilization. Diagnosis has improved nowadays. Vasopressor would ideally be identified early. Unfortunately, this is not always possible. Clinically, an examiner is occasionally able to palpate or directly see a tubular fetal vessel in the membranes overlying the presenting part. With transvaginal sonography, cord vessel may be seen inserting into the membranes rather than directly into the placenta, with vessels running above the cervical internal os. And routine color Doppler interrogation of placental cord insertion site, particularly in cases of placenta previa or low-lying placenta, may aid its detection. Also, we have cord abnormalities capable of impending blood flow. It's knots. So knots, false information that the knots result from kicking of the vessels to accommodate to the length of the cord. But true knots are caused by fetal movement and are seen in approximately 1% of births. They are especially common and dangerous in monoamniotic twins. When true knots are associated with singleton fetuses, the stillbirth risk is increased 4 to 10-fold. Abnormal fetal heart rate tracing are common, often encountered during labor. However, southern delivery rates are not increased and cord blood acid-base values are usually normal. Also, we have sometimes loops. Cord loops are frequently encountered and are caused by coiling around the various fetal parts during movements. As they are more common with longer cords. A cord around the neck, a nodule cord, is extremely common. Usually one loop is reported in 20 to 34% of deliveries, two loops in 2.5 to 5%, and three loops in 0.2 to 5% of the deliveries. During the labor, these loops can result in fetal heart rate decelerations that persist during contractions. Up to 20% of fetuses with a nodule cord have moderate to severe variable heart rate decelerations, and these are associated with a lower umbilical artery pH. We have also cord abnormality capable of impeding blood flow. Its coiling of the cord around the neck is uncommon, cause antepartum fetal death or neurological damage. Entwined cords cause intrapartum complications. As labor progresses and there is fetal descent, contraction may compress the cord vessels, how I told before, and fetal heart rate decelerations that persist until the contraction cases. So I told this all before, and we have torsion and strictures in umbilical cords. Strictures is a focal narrowing of its diameter that usually develops near the fetal cord insertion. Its characterized pathological features of strictures are absence of Wharton jelly and stenosis or obliteration of cord vessels at the narrow segment. In most instances, the fetus is stillborn. Even less common is a cord stricture caused by amniotic band. And sometimes we have torsions in umbilical cord. It's very rare cases. It results from fetal movement during which the cord normally becomes twisted and fetal circulation is compromised. And umbilical cord hematomas are uncommon and have been associated with abnormal cord length, umbilical vessel aneurysms, trauma, enlargement umbilical vessels, venipuncture, and phonitis. They can follow varix rupture, which is usually of the umbilical vein. They are organized sonographically as echoic masses that lack blood flow. Umbilical cord vessel thromboses are in utero events. Approximately 70% are venous, 20% are venous and arterial, and 10% are arterial thrombosis. Compared with venous thrombosis, those is artery have higher perinatal morbidity and mortality rates and rare associated with fetal growth restriction, fetal acidosis, and stillbirths. And we have sometimes cysts. The cysts occasionally are found along the course of the cord. They are designated according to their organ. True cysts are epithelium-lined remnants of the allantoic or vitelline ducts and tend to be located closer to the petal insertion site. In contrast, the more common pseudocysts from local degeneration of Vartanal jelly and occur anywhere along the cord. Both have a similar sonographic appearance, and single umbilical cord cysts identified in the first trimester tend to resolve completely. However, multiple cysts may be portent miscarriage or aneuploidy. Cysts persisting beyond this time are associated with a risk for structural defects and chromosome anomalies. Pathological examination, so placenta and cord includes a number of vessels should be examined grossly following all deliveries. Decision to request pathological examination will depend on clinical and placental findings. Pathological examination in the following circumstances, we have to do it when we have prenatal death, preterm deliveries, fetal growth abnormalities, fetal malformations, hydrops, any other fetal disorders, multiply pregnancies, maternal disorders, and cross-placental lesion. Amniotic fluid have several roles during pregnancy. It creates a physical space for fetal movement, which is necessary for normal muscle skeleton development. It permits fetal swallowing, essential for gastrointestinal tract development, and fetal breathing, necessary for lung development. Amniotic fluid guards against umbilical cord compression and protects the fetus from trauma. It even has bacteriostatic properties. Amniotic fluid volume abnormalities may reflect a problem with fluid production or its circulation, such as underlying fetal or placental pathology. These volume extremes may be associated with increased risk for adverse pregnancy outcomes. So amniotic fluid chemical composition is 99% water and 1-2% solids, half organic and half inorganic. Organic constituents include carbohydrates as glucose and fructose, proteins, and hormones. The inorganic constituents are similar to those found in the maternal plasma as natrium and fluor. Organ of liquor amnion, it's a fetal organ, it is fetal urine. Actually, first fetal urination is primary amniotic fluid source by the second half of pregnancy. By term, fetal urine production may exceed to 1 liter per day, such as entire amniotic fluid volume is recirculated on a daily basis. Fetal urine osmolality is significantly hypotonic to that of maternal and fetal plasma and similar to that of amniotic fluid. Also, we have in amniotic fluid secretion from the amniotic epithelium, diffusion from the umbilical cord vessel, transudation through fetal skin, and secretion from bronchial mucosa, buccal mucosa, and salivary glands. From maternal organs, liquor is a filtrate from maternal plasma. State of liquor amni, first, it's fetal swallowing, and second, maternal transudation into maternal circulation. Function of the liquor amnion. First function during pregnancy, it's protection of fetus. How I told already, it keeps the temperature constant, it allows free fetal movements, prevents adhesion between amnion and fetal skin, nutrition, acts as a medium for fetal extraction, forms a close sac around the fetus, preventing escape of infection. And during the labor, it's make dilatation of the cervix. It prevents direct compression of the plasma between the uterine wall and fetus during uterine contraction, thus avoiding fetal asphyxia. And during the labor, when the membranes rupture, the fluid washes the birth canal from above downwards, thus removing away any infections in maternal vagina. Amniotic fluid index, it's a method of amniotic fluid volume assessment. As with a single deepest fluid pocket measurement, the ultrasound transducer is held perpendicular to the floor and parallel to the long axis of the pregnant woman. The uterus is divided into 4 equal quadrats, the right and left upper and lower quadrats respectively. The amniotic fluid index is the sum of the single deepest pocket from each quadrant. A fluid pocket is generally used to a fluid pocket may contain fetal parts or umbilical cord loops, but these are not included in the measurement. Color Doppler is generally used to verify that umbilical cord is included in the measurement. This may result in greater consistency and in reduction of intra-observation. It has been reported, however, that color Doppler results in lower amniotic fluid index measurement, this potentially leading to overdiagnosis of oligohydroamnions. Definition is excessive amount of amniotic fluid, more than 2 liters. Acute polyhydramnions is very rare, usually occurs in early pregnancy and is almost always associated with monozygote twins. A large amount of fluid accumulates in a few days. It leads to abortion or preterm labor. Chronic polyhydramnions, it's calmer than acute. Usually in late pregnancy, the fluids accumulate slowly. Causes of polyhydramnions, it's fetal malformations from gastrointestinal tract, it's esophageal or duodenal atresia, tracheoesophageal fistulas. From CNS is anencephaly. It's also maybe twin transfusion, fetal polyuria, or hydrops fetalis, congestive heart failure, severe anemia, or hypoproteinemia. It's placental transduction, and also diabetes mellitus. Diagnosis of polyhydramnios main symptoms is dyspnea, edema, abdominal distension, preterm labor. During the abdominal examination, we will see that the uterus is bigger than we expected. When we will palpate the uterus, we will have palatable fetus, and it will be difficult to hear fetal heart sound. And during ultrasound examination, we will see excessive amniotic fluid. We may have fetal abnormalities. Assess fetal well-being, its biophysical profile and Doppler, and fetal karyotyping. During pregnancy, we may have abortions, preterm labors, preterm ruptures of membranes, cord prolapse, placental abruptions, malpresentation, non-engagement of the presenting part, or pressure symptoms as dyspnea or palpitation and edema of lower limbs. And complication during pregnancy, we may have premature rupture of membranes, prolapse of arm, cord, or both, abruptio placenta due to rapid escape of liquid with premature separation of placenta. And we may have splanchnic knock occurs if the fluid escapes rapidly, so the pressure exerted by the uterus on the splanchnic vessels drop suddenly, leading to pooling of blood in the splanchnic area and shock. And postpartum hemorrhage due to uterine atony due to overdistension of the uterus, retained placenta, and prolonged labor. And during puerperium, the uterus may take a longer time to involute. When it comes to management, unfortunately, there's no treatment. It's not effective. Bed rest, diuretics, water or salt restriction. Usually we hospitalize the patient if we see the patient has dyspnea, abdominal pain, or difficult ambulation. And Dosent therapy may be treated. Patient with endometacin therapy impairs lung liquid production when the low fluid movement across the fetal membranes. And complications we may have its premature closure of ducts arterials, impairment of renal function, and cerebral vasoconstriction, so not used after 35 weeks. So endometriosis therapy we are not using after 35 weeks. Amniocentesis may be done to relieve maternal distress and to test for fetal lung maturity. And we have complications, ruptured membrane, chorioamniotes, and placental abruptions, and preterm labor. Oligohydroamnion, it's when diminished amniotic fluid less than 500 milliliters. By ultrasound, the ventricle diameter of the largest pocket of amnion fluid measured 2 centimeters or less. The amniotic fluid index is 5 centimeters or less. It's very rare cases of pregnancy. Time of onset may be mid-gestation or third trimester. Causes of oligohydroamnion, it may be fetal and maternal causes. Fetal causes, it's renal cause, 57%. Renal agenesis, it's a Potter syndrome. Polycystic kidney of fetus, urethral obstructions. And maternal cases may be uteroplacental insufficiency, preeclampsia, and there may be also placental cases. It's twin transfusion and drug cases if prostaglandin synthase inhibitors as NSAID, and idiopathic cases. And here you can see the picture of a baby who was born with Potter syndrome. How we know amniotic fluid supports cushions and protect the developing fetus. When there is too little amniotic fluid, normal pressures that is exerted on the fetus during pregnancy can cause certain physical features, such as distinctive facial features or skeletal abnormalities. When oligohydroamnion is present from early in pregnancy, the lungs are also undeveloped, which can lead to severe breathing difficulties. Most often, this condition is caused by absence of both kidneys. This is sometimes referred to as classic Potter syndrome. Potter syndrome can also result from other conditions, including polycystic kidney disease, malformed or underdeveloped kidneys, and obstructive uropathy, in which urine cannot be voided from the bladder and builds up with the kidneys. Sometimes later during gestation, there may be amniotic fluid leakage. This will not lead to Potter syndrome. Potter syndrome is an extremely serious condition and is often fatal or shortly after birth, mainly due to pulmonary hypoplasia. Because of lack of amniotic fluid, to protect the developing fetus, normal pressure from the uterine wall can affect the growth and development of the fetus. Such pressure may cause distinctive facial features, including a recrested chin, a flattened, depressed bridge of the nose, eyes that are spaced further apart than normal, low set ears that lack a cartilage. We call it also Potter ears, abnormally prominent skin folds in the inner corner of the eyes, and a crease beneath the lower lips. This collection of facial features is sometimes referred to as Potter faces. Sometimes there are abnormalities in the development of arms and legs, lack of the formation of half of the spine, absence of the lower portion of the spine, congenital heart defects or abnormalities of the eyes, such as cataracts or displacement or dislocation of the lenses of the eyes. And infants with Potter syndrome are often born prematurely and are small for their gestational age, which means they are smaller than would normally be expected for how far along the pregnancy is.